Tibial resection requires the frontal plane alignment of the tibial resection guide to be perpendicular in the AP plane. This tibial resection guide is inclined posteriorly and is using a distal strap that connects to the ankle. Once the strap is connected, the proximal portion of the guide can be raised or lowered using the alignment rod, and the guide should be placed in the frontal plane to be perpendicular to the frontal plane axis. The resection caliper guide can be placed on the upper portion of the guide to find the lowest point of resection, and this can be adjusted depending on the pathology encountered. The guide can be positioned medial laterally in the distal plane using the micrometer type guide. The guide itself can be moved anteriorly and posteriorly to get the desired posterior inclination angle, which lies between 5 and 10 degrees. The guide is then pinned into place. The dimensional caliper removed, and the adjustment block can be moved upwards or downwards depending on the amount of bone resection required. Note that the inclination angle is anatomically inclined posteriorly to approximate the patient's own posterior inclination angle. Once this has been performed, the guide can be removed, and the femoral resection guide is then positioned into place. The femoral templates are used to assess the actual dimension of the femoral resection guide. Note this size 3 template matches just about identically the size of the bony articulation of the femur. Taking the size 3 trial, in this case, it seems to be a superior fit over the size 4, which was too large. By reversing the size 3 trial and placing it on the anterior femur, we can place it and use it as a guide medial laterally to be dimensionally correct. The femoral resection guide is mounted to its alignment instrument, placed on the center of the femoral shaft. Once the femoral resection guide is aligned, a temporary pin is used to hold it in position. The 9mm drill is passed through the guide and runs up the shaft of the femur in line with the alignment rod. The alignment rod is removed. The 9mm fluted rod is placed into the drill hole, and the temporary pin is removed to allow free axial rotation of the femoral resection guide. The femoral guide positioner is then placed into the inferior slot of the femoral resection guide and on the anterior surface of the tibia. The guide is adjusted to allow tension to develop between the guide and the upper surface of the tibia, placing the medial and lateral collateral ligaments in tension. The alignment rod can be used to assess the amount of tension in either compartment. This alignment rod also can be brought down to the tibia to check for proper tibial resection angle. The guide is then pinned into place, giving equal compartment tension medially and laterally. The anterior femur is then resected with a power saw through the capture plate. The capture plate is then removed and placed on the inferior portion of the guide, and the posterior femoral condyles are resected with a power saw. The slap hammer may be used to remove the 9mm rod in situations where the bone is quite tight. And the guide pins may then also be removed. The spacer block can then be placed in the flexion gap, and the exact amount of flexion gap is determined. The guide can be used to assess the medial and lateral compartment tension. The compartment tension can be assessed with the spacer block in place and by rocking the alignment rod medially and laterally to assess a maximum of 1 millimeter of separation between the tibial surface and the guide. This gives a proper flexion tension. The distal femoral resection proceeds after placing the referencing guide into the intramedullary canal, and the alignment rod can be passed through the guide and aligned over the femoral head center. This alignment position can be arbitrary and can be used with the anterior superior iliac spine using 1 to 2 finger breaths medial to this anatomic landmark to give this orientation. Alternatively, the guide can be aligned at 3 degrees, 4 degrees, or 5 degrees, depending upon the patient's height. The guide is drilled and pinned. The guide is removed from the pins, and the distal femoral resection guide is placed on to the pin surface period. The distal femoral guide positioner is then placed into the inferior slot of the distal femoral resection guide and placed into the extended knee joint, making contact with the proximal tibia. This gap represents the same gap in extension as was determined for the flexion gap. The saw capture plate is then placed on the guide, and the distal femoral resection can be made with a power saw. The guide is removed. The distal femoral cutting jig can be used to assess the alignment of that cut. The knee is then brought into full extension, and the spacer block used for the flexion gap is inserted between the femur and tibia to assess the extension gap. Axial and frontal plane alignment can be assessed using the alignment rod, which is brought to the center of the femoral head, down to the center of the ankle joint. The finishing resections of the distal femur can then be made through one guide, which is centered on the epicondyles of the femur. It is pinned into place. And the 2 drill holes are made with a 1/4-inch stop drill. The anterior intercondylar cut is then outlined with a power saw medially and laterally in its slot. The bone is then removed using an osteotome from either the inferior or superior surface. The posterior condylar cut can then be made with a power saw or osteotome, making sure to remove the posterior bony contents that will prevent impingement into the bearing surfaces. The anterior chamfer cut and the posterior chamfer cuts then can be made also with a power saw through their respective slots. The tibial preparation is a rapid, easy to perform procedure which involves taking the properly sized template that fits just within the bony borders of the tibia, and this template is then pinned into place, and using a conical reamer, the central conical preparation is completed in one motion. Pins are removed and the template is removed. Trial reduction begins with implantation of the properly selected tibial trial, then the rotating platform bearing, followed by installation of the correct size femoral component trial, initially impacted at 110 degrees of flexion and finally impacted in less than 90 degrees of flexion to prevent rocking of the tibial component. The patella is everted, and when resected, is resected at the level of the quadriceps and patella tendons, respectively. The patella template is placed in its anatomical position, the patella is everted, and 3 marks are made to demonstrate the marking position of the trial patella component. The trial patella component is then squeezed into position with the patella clamp. A trial reduction of all components is then made to assess proper patella tracking, and if lateral release is necessary, it should be performed at this time. The patella template is then applied to the patella, and the 3 lug holes are prepared using the lug hole burr. These will allow for proper cementation and fixation of the patella component. The trials may be removed using the disimpactor on the femoral component, the bearing is then removed, and the tibial component can be disimpacted using the levering bar. Final component implantation proceeds with installing the rotating platform tibial component initially. This is impacted into place after proper cementation, followed by the rotating platform bearing, then followed by the cemented femoral component, which is attached to its holder impactor using a rotating motion on the handle, which then can be rotated to deliver final impaction with the knee flexed less than 90 degrees. The patella is then cemented into place into the 3 lug holes previously prepared, and the patella clamp can be used to squeeze it in position and hold the patella while excess cement is removed. Now that all components have been completely installed, they are checked for range of motion, and any impinging tissues should be removed at this time. A full active range of motion without any patella subluxation should be the final observation following correct installation of all components.